We're going to start with the final session. I was here for the beginning, and I will be here for the end, at least for the many of you didn't think I could do that. So I'm Neil Ampel from University of Arizona, Mayo Clinic in Arizona, and the final session is current status of patient management. And our first speaker is Fariba Donovan, Assistant Professor of Medicine at the University of Arizona, and Assistant Professor at the Valley Fever Center for Excellence. Fariba is going to talk about diagnostics, current methods, and challenges.
Can you hear me? Thank you so much for, thank you actually the Academy for inviting me and the organizing committee. This is a wonderful meeting. It's an honor to be here. Hopefully I don't move this too fast. Let's see here. Okay, so today I'd like to talk about before we start the diagnostic, I'd like to talk about the challenges that are involved with the actually diagnosis of the disease before we get to the diagnostics. And then we'll talk about the current available tests that we use, all of us, and all their limitations, and then ultimately what is available now, what are we doing to improve our diagnostics, what are the new tests that are coming up, and actually I refer you to our 3 speakers tomorrow before the break, tomorrow morning. There'll be 3 great lectures and discussions about that. So, valley fever awareness. That's really one of the major aspects of improving diagnosis in valley fever. And this is one of the challenges that we have been dealing with in Arizona. So this is the current clinical practice for valley fever. As you see, 25 to 30% of valley fever cases or community-acquired cases in Arizona, community-acquired pneumonia in Arizona, are due to valley fever. Take a guess how many of these people actually get tested for valley fever. Here we are, lesser than 15%. So as the other speakers before me talked about this, it's really important to think about the disease, and knowing about the disease helps a lot. We know that about 1,000 medical licenses are issued in Arizona every year, new licenses. And out of those, about 12% of them receive their licenses in Arizona. So we assume that to some extent they know about the disease. 40% had no graduate medical education in Arizona, so lesser familiar with the disease and presentation of it, obviously. 80% of these people, when they surveyed, they didn't know that it is reportable in Arizona. They didn't know if there is or there is not a vaccine for it. And of course, 40% of these clinicians, when we ask them, do you like, when you see somebody that potentially has valley fever, do you like to treat these people, continue following? No, I'll refer them to either you guys or pulmonology. So you see the battle that we have and the challenges that we have in hand. This is a study we did, actually 2 independent studies. We did it in Banner University Medical Center in Tucson, and independent study simultaneously in Phoenix, and we almost had identical results. You see that the delays in valley fever diagnosis, 43% of these diagnoses delayed more than a month. And when I say more than a month, it's not only for acute pulmonary disease, but even disseminated disease. So you imagine the amount of complications that come with that delayed in diagnosis, amount of anxiety, and as previous speakers mentioned, cost of healthcare that comes with this delay is significant. This is a slide about the number of patients with community-acquired pneumonia in Banner Medical Group and Banner University Medical Group in about 3 years total. And as you see here, people who had the diagnosis, ICD code of pneumonia, were about 2,300. Now, if you look at the number of people that they considered COXI, was only 57. And out of those, when they got tested, 43 of them were positive. So we have a significant challenge to bring these numbers up so actually people think about it. So delay in diagnosis was significant. Substantial cost, healthcare utilization, patients' anxiety goes with that delay. And of course, significant amount of antibiotic use. I have in one of my slides, at least people receive 3 courses of antibiotics. So there goes our antibiotic stewardship when these people don't get diagnosed early on. So one step that we have taken, and I should say that it is to some extent helping, is improving our awareness. And Banner Health, together with us, University of Arizona Valley Fever Center, we are trying to change the way that Arizona clinicians recognize and manage the patients who have valley fever. We try to actually expand the role of these physicians in earlier diagnosis and management of uncomplicated disease. They don't have to send the patient to us if they are comfortable diagnosing and managing them. And to this, we actually at Valley Fever Center website, we have several resources, both wall posters, nurse practitioner referral supports, as well as we have tutorials and several ways to actually improve the general public and community providers' knowledge in what is valley fever, how it is presented, and how you can manage it. And here we are here to help you if there is anything else that you need on that end. So now, switching to what I'm supposed to talk about, the diagnostics. What are the usual diagnostic methods that we use in clinical setting? Of course, serology. I'll get back to that in this next slide. Of course, we have culture and pathology. You heard about the complications that comes with culture. You need a specific place. You have to be in BL3 lab. You have to take a special precaution to avoid exposure. And of course, you have to have a sample to culture. And the other thing is pathology. If you have a sample that we biopsy, it's an excellent way of identifying the spheroid, but it's not always available. So limitations there. Imaging. Sometimes we use imaging, chest X-ray or CAT scan, or sometimes, as other speakers mentioned, PET scan. And this is some, in our area with pulmonary nodule, we always assume valley fever. However, it's not confirmatory test. We have to biopsy that. So there we have another invasive measure, more cost and morbidities for patient. Skin test, which is a great way of identifying adaptive immunity, delayed response, but it's not always available. Injection site reactions had issues. But I'm glad that actually our previous speaker mentioned that it's more readily used in prison setting than in normal population out there. So as a clinician, we usually go with serology, the easiest, fastest, and most readily available. So this slide, actually, I used several references, but main one is Dr. Papagiannis in 1990. Dr. Ampel here actually referred to that in 2010 again. The initial test that was done to percipitin is a heat-stable 120 kilodalton beta-glucosidase. To percipitin and immunodiffusion tests that are being done now detects the IgM, which is an early antibody, earlier stages of the disease. The next test that we always see is complement fixation heat labile chitinase. This is either complement fixation or immunodiffusion. Usually comes later, 2 or 3 weeks after the disease starts, and it's IgG reaction. So both of these two, immunodiffusion, need immunodiffusion in agar. They are specific, acceptable sensitivity. It takes time. Usually, I don't know if in your center, maybe George would be a good person to tell us how many days it takes for them. But in our case, usually we have to wait about a week to 10 days for this to come back. CF titers that we use, previously we used it more as prognostic values, but it's not always corresponding with the disease presentation. So we have to be very careful about that. So now, this is actually an old diagram that I put here from Dr. Papagiannis, who refers to 1957 paper in his publication. Again, talking about the same thing. 2 precipitin IgM is earlier stages of the disease and comes down, and then complement fixation IgG goes back up later on. And this is only a shorter span of time, longer time during the disease, very clear difference in the presentation. And of course, the skin test is later on and stays longer, and evidence of previous infection. So what do we now use is an enzyme immunoassay, same studies. If it is positive, we always say, okay, we got the diagnosis, we confirmed the diagnosis. However, if it is negative, I don't know if any of the clinicians in the room, in the right setting of clinical presentation, can say patient doesn't have it because test is negative. So we always repeat the test to increase the sensitivity. Still, the sensitivity is an issue. So what is the best test? And I actually reviewed a couple of different publications to see current commercially available tests. They all have variable accuracy. And that's the reality that we face these days. I made a table of these papers. One of them I mentioned here, about 3 different tests that are now currently available in the market, MiraVista, Meridian, and IMI. The sensitivity of EIA by MiraVista for IgG is 87%. As you go down, you see that the sensitivity goes down. And so is for IgM, a little bit lesser actually than IgG. Specificity of all 3 tests are very similar, actually very good. So what should we order? Patients always ask us, or other providers in the community, what's the best test? So there was this new test that IMI introduced in the market, lateral flow assay. We actually, in our center, we studied this test and compared it to enzyme immunoassay, our standard test, both of them made by IMI. We enrolled 392 patients prospectively. These were people who suspected to have cocci, and compared these 2 tests. Most of this disease presentation was acute pulmonary. Most people were hospitalized. Now here is the healthcare utilization. Most of them had more than 3 previous healthcare facility visits, and most of them had more than 3 antibiotic courses. One side project that we did on this project was checking the procalcitonin on this population, and in 83% of these people, it was low in people who had actually positive cocci. So this would be a good indicator for us to avoid antibiotic overuse if this procalcitonin is lower, and if we actually test it for these people. So going back to our lateral flow assay, how does it work? How does it compare with our standard EIA and immunodiffusion? And as you see here, sensitivity of lateral flow assay compared to EIA was only 31%. And in compared to immunodiffusion, 41%. But when you compare the specificity, actually was very good. We were hoping that this is the test that we can use as a point of care for early diagnosis, and then maybe confirm that with other tests. So now what we know about this test is it's a great test. It's very fast. It takes only 30 minutes. Small amount of serum will do it for you. Very high specificity, but what's the next step is we need to improve our sensitivity. And in summary, I just wanted to mention that again, before we talk about diagnostics, we really have to talk about diagnosis of the disease. What's our role to raise awareness, to improve the diagnosis of this disease in every clinic, in outpatient settings, and in the community. The next step is, of course, expanding the role of these primary care providers for these people who are in our community. Some of them have not heard about valley fever. And we are working on that. It's improving, but we are not there yet. And then the last step, of course, is developing a very sensitive and specific point of care that is fast and helps us to diagnose this disease earlier on compared to right now. And thank you for those 3 speakers tomorrow. We look forward to hear about you and new technology. And that's it. Thank you.
Thank you, Fariba.